I'm delighted to welcome everyone to today's Grand Rounds. Thank you for joining us. My name is Femi Bankole. I'm an associate professor and neurosurgeon at Lagos University Teaching Hospital. We have several stakeholders from various parts of the world, from North America, from Africa, Nigeria, obviously, joining us today. Also, neurosurgeons, radiologists, neurologists, some of our nurses, as well as potentially some of the admin people in the hospital where we work. We are trying to put these ground rounds on a bi-monthly basis, and we've done quite a few. The title for today's ground round is Intracranial Arteriovenous Malformations and Treatment. Before I introduce our moderator for today and invite Dr. Ranu Chatterjee, who is an associate professor of neurosurgery and neurology and the director of neuroendovascular intervention fellowship and co-director of the neurointerventional radiology program at the Washington University School of Medicine, to introduce our presenter for today. Let me do a few housekeeping rules. So please mute your microphone except you are called upon by the moderator or presenter. When sharing video, please be mindful of what may be in your background. We always expect to have a few technological hiccups, but fortunately, we haven't had that as many. But please bear with us if they do occur, and we'll just wait them out. At the end of the presentations, we will have the opportunity to ask questions. So if you have a question at any point in time, you can just put it on the chat box in the chat session during the Q&A session we will be attended to. Our moderator, Dr. Kafo, is no stranger to those who have joined previous grand rounds. But for those who may be joining for the first time, Dr. Kafo is the driving force and brain behind these sessions, and he's a neurosurgeon and the co-founder of the West African Stroke Initiative. He recently completed his endovascular surgical neurointerventional fellowship at the Mallinckrodt Institute of Radiology at WashU. So congratulations, Dr. Kafo, on that. So I'm going to start modification today. After Dr. Moran's talk, Dr. Tayo Ojo, who is one of my colleagues here at the Lagos University Hospital, will also be giving a short talk on our local experience and what we are seeing in our region. So I'm going to hand over to Dr. Chatterjee now to introduce our presenter for today. Dr. Chatterjee, over to you. Thank you.
Thank you, Dr. Bankole, and thank you, Dr. Akafo. Thank to all of you for having us. I have the distinct honor of introducing Dr. Christopher Moran. He has been, for as long as I can remember, one of my most important mentors. So briefly, Dr. Moran graduated from his undergraduate degree at the University of Notre Dame in 1970, and then he graduated from his undergraduate after 1970. Graduated from medical school at the St. Louis University School of Medicine in 1974, and then he completed residency and fellowship between 1974 and 1978. Since then, he's been basically a foundation here at the Mallinckrodt Institute of Radiology in St. Louis. And though he's spent decades, literally decades in St. Louis, his impact is felt around the US and internationally. He has hundreds of publications. He's mentored over 47 fellows. His impact is immense. He was recognized for probably his most impactful investigation in the PUFS trial, which was looking at the initial benefit of pipeline flow diversion. But when we talk to people around the country in the US who are in this space doing neurointerventional, the number one thing we hear when we mention Dr. Moran is, oh, yes, he was someone who proctored someone that I know or myself in a case. So he has literally proctored hundreds of people, close to thousands of people in terms of his impact. And in proctoring, he has taught people how to be interventionalists. And so he is a mentor's mentor. He is a teacher's teacher. And now he is often asked. Good morning. Hi, good morning. He is often asked to give lectures on how to teach. But it is my distinct honor and pleasure to introduce
The
Dr.
host needs to give us permission to share the screen.
Hi, Trish. Yes, we're going to do that. Dr. Chatterjee is just introducing Dr.
We
Moran.
can't hear you. Where's your speakers?
Can you hear me, Trish?
Hi, Uche, I can hear you.
Okay.
So
I
your
think
audio
they're
is
just-
coming through. I
yeah.
think it's on their end.
It's on their end. Okay. So, sorry, Dr. Chatterjee, can you just carry on? Well, I'll just try and get us.
Oh yeah, no, that was my introduction, and so I wanted with distinct pleasure to introduce Dr. Moran. I think we're all here to talk, to hear from him, and so wanted to give him the floor.
We're just trying to get his camera going.
Yeah. Hi, Trish. Can you hear us now?
He's muted. They need to unmute. It's possible.
Yeah, we just have Peggy going over to help him sort out that connection. Just give us a minute.
All right, they're unmuted now, so we should be able to hear. Okay, muted again. Yeah, well, we did talk about technological hitches at the beginning, so please just give us a few minutes to sort this out. Mm-hmm.
There he is. Can you hear us, Trish, Dr. Moran?
I am here, but we're having some technical difficulties.
We can see your screen now, so. I just finished my glowing and introduction, so the floor is yours.
Well, thank you. I hope
Yeah.
this isn't a sign of things to come. We're struggling to get, shall we say, my talk up. We've had it this morning, and sometimes those things are difficult.
We can
I
see
think
you.
we have it now.
Yeah.
Yep.
Good morning.
Good
If you
morning.
want to click on presentation mode.
I think so.
Perfect.
So, Yushena asked me to give a talk on AVMs. I'm going to go through how we approach them. Some of it's going to be data from the literature, a little bit of our own data, and more of our own experience than anything else. So if at any time you have a question, rather than putting it in the chat room, which I may or may not get, just please unmute and ask me. So I serve as a consultant for Microvention, Medtronic, Stryker, Cerenovus, and Balt. At one time, I was the medical director of Medtronic Neurovascular. That was some years in the past. This talk is also made in collaboration with Dr. DeWitt Cross, who I've stood next to for hours and hours in the 1990s as he and I developed the interventional service. He was a very, very, very good interventionist, very thoughtful, very calm and quieting, and he was an amazing man. He's still with us, but just not working. So this is a slide from the Aneurysm Foundation showing the AVM. I know the group, particularly the neurosurgeons, have seen AVMs in person. The neuroradiologists and probably neurologists should go to the OR sometime and look at an AVM and see that racemose collection of vessels, and then also the nidus. So with an AVM, what happens is that the blood gets to go from a high pressure system into a low pressure system. And you can see how we're going in this particular slide from the basilar into the PCA, distally in the PCA, and then as we get close to the nidus, it's significantly lower in pressure. So you have that drive, that pressure head, and that's one of the problems, because there is no interface of the normal smaller arterioles, capillaries, then the bed, and then the small venules and the larger venules. So it's going pretty quickly from the arteries to the veins, and particularly in a fistula. And I think I have at least one fistula to show you. So there are multiple types. I'm going to spend most of the time on peel AVMs today. I'll show one dural. They are, the mixed ones are uncommon, and I'll give you some of the ideas how often we see this disease. It is, we spend a lot of time with it, but it is relatively uncommon. Most of the AVMs are supratentorial, about 10% are infratentorial. And here is an example from a large left frontal AVM, kind of similar to that slide that I showed. You see the enlarged vessels, and now you have the area of the nidus, and in the frontal projection, you can actually see the veins draining. It's a film. Remember, when we film, it's every other frame. You go from the AP to the lateral, then back to the AP, back to the lateral, so that you don't get fog. It's one of the things that helps you see things better. This is a dural malformation. We have the internal carotid, external carotid. The area of the nidus is right in here. It's probably in the walls of the transverse sigmoid junction. So it's going right through. And the way that this is treated is from either embolization from probably the middle meningeal, also the occipital, and sometimes you can get both from one particular vessel. And also there's surgical ways of treating this, although it tends to be, even when it's skeletonized, they want to come back. And ordinarily when you are treating a dural fistula, if you get it into the vein, if you get it to that interface and the artery, it usually will be cured. So how often do we see cerebral AVMs? In autopsy studies, it's somewhere between up to 1%. There's several different studies. It says that they're 1/4 as common as aneurysms. You know, in aneurysms, they're about 5%, 8% of the, maybe even 10%. If you look at the very small aneurysms, very prevalent. The other thing is cerebral venous malformation, DVAs. They are really common, about 3%, 4% of the population. And a venous malformation is just a normal vein going through the brain rather than on the surface of the brain. And most of the time they don't cause problems. Occasionally when they're associated with the cavernoma, there can be problems. And occasionally there can be some stenosis as it's draining, and the patient will develop a venous infarct. So how do they present? Many of them are asymptomatic. Patients will have headaches occasionally, and one of the problems with headaches is everybody has headaches. So that doesn't differentiate things. But seizures are a big deal, and the patients then get care. Also, occasionally the patients, about half the time, they'll present with a hemorrhage, and there'll be a parenchymal hemorrhage, subarachnoid, interventricular. Since the small AVMs are much more common than the medium size and the large AVMs, most of the hemorrhages are going to be from the small AVMs. Nearly half the patients will have seizures. And when I've talked with the patient, when I'm going to treat them as part of the endovascular, I tell them the reason I'm doing this is to help the surgeon or help the radiotherapist. It is unlikely that I'm going to cure you, and it is unlikely I'm going to make your seizures better. What I'm trying to do is keep you from bleeding. And that's the most important thing. I'm going to keep you from bleeding. We also see some progressive neurologic deficits because of venous hypertension, or because there's a steal phenomena that all the blood's going from now the relatively normal adjacent brain into the AVM. Seeing congestive heart failure is usually uncommon. We'll see that when we talk about kids and vena Galen malformations. So this is a diagram. The chart is a little bit busy, but what I'd like you to notice that the headache, which are these dotted are bars, is the most frequent presentation, and it tends to occur around 20 to 30 years of age, and that declines as we age. The other thing that we have is the seizures, which is the second most common. So remember headache number 1, seizures number 2. So what we need to do is figure out who we need to treat. And we're going to talk about Aruba here in just a minute. I think that's an important thing, but I think it's also been a little bit discredited. So at the time that we see the patient for the first time, what are their risks of bleeding? And if we see them that they've bled, what are their risks of rebleeding? And that's a very important aspect. Unruptured, 2 to 3% a year that will rupture. If they have ruptured, that first year is when they're at highest risk, usually 6-7%. And then it goes back to the normal 2 to 3% annually. Now you have something to really consider if you have a 20-year-old. It's really different if you have an 80-year-old. Should you be treating the 80-year-old? Particularly an unruptured AVM. And most of the time the patients will decline therapy. There are some things that would suggest that smaller AVMs are more prone to bleeding. I don't know whether that's true. I think it's because there's more smaller AVMs. And I think that's probably one of the reasons. The other thing that we see are nidal aneurysms or aneurysms on a supplying vessel. And supposedly with a deep venous drainage. Now, when you look at Spetzer in just a minute, that's one of the criteria to make that AVM more at risk for surgical therapy. When they do bleed, though, it's about a 10% mortality, and the morbidity is probably on the order of 30%. So it is a big deal when you're talking to an unruptured patient who's 20 years old. Hey, if you have 60 years of life left, it doesn't mean that at the end of that 60 years, you're going to have had a deficit from a bleed, but it does mean that you're at risk. And most of the time, the young people want it treated. So physical examination is helpful. Sometimes you can hear the bruit, but most of the time in the noisy hospital areas, it's difficult to hear the bruit. And most of the places with noise nowadays, it's very difficult. The only part that ultrasound plays, I think, is in vena Galen malformations in the neonates or even in utero. MRI, MRA, I think MRA is helpful to see not only the nidus, but to see what's been going on with the adjacent brain. MRA, I think, gives you a hint of what's going on, but I believe arteriography, I believe CTA more than I do MRA. And then angiography. Angiography is essential because it tells you what you're going to be able to do. Actually, at times, patients will come in extremis with a clot and need to have that evacuated. And occasionally, you will see an AVM at the depths of the clot. Most of the time at our institution, we leave that alone and come back when the patient's recovered. What we're trying to do is save the patient's life. So vena Galen malformation, the ultrasound, and you can see the large vena Galen in the sagittal view, and there's the draining vein. The MR shows the exact same thing. Again, the nidus, you can see the draining vein. Most of the time, the draining vein will be the vein of the prosencephalon, and will be more horizontal or even more vertical than in this particular example. But you actually get a lot of information here. You can see that the ACA is coming around supplying it. You see that the carotid is hypertrophied, and then you have vessels at the back. So that's off the PCA, which isn't surprising. So this is probably going to be a choroidal type AVM vena Galen malformation. Now, in just a second here, here's the arteriogram. You can see the PCAs supplying it. You can see that there's a branch coming here, which is probably one of the ACA branches, and the venous drainage. For a while in the mid 1990s, late 1990s, it was attractive to treat these from the venous approach, and one would go retrograde and get up into the vena Galen itself and put numerous coils. In this particular instance, it would be difficult because there's really no neck to the vena Galen in that straight sinus. So that would be very difficult. And oftentimes what one would need to do was slow the flow, and you could do so by putting a bunch of coils in the vena Galen. In this instance, you would need to put some sort of device to be able to hold the coils in place. And then you would go into the multiple feeders with a microcatheter and inject embolic material, either glue or onyx. This is a vein of Galen AVM. Different than vein of Galen, which I just showed you, malformation, is a congenital abnormality, to be sure, a developmental abnormality. I think AVMs are in part a congenital abnormality. But you notice this child has hydrocephalus, and you see in this sagittal view, there's the nidus, here's a draining vein, and there's another draining vein. Child was developmentally normal, had fallen, and it was discovered incidentally when it was realized that the head measurement was larger than it should be. The arteriogram, most of the supply is coming here from the PCA in this AP, and from the ACA, you see the area of the nidus. So in contrast to the vena Galen malformation, which has no nidus, it's a fistula. It goes from the artery to the vena Galen. In this instance, it goes into a nidus into the vein. This is from the PCA, placing a microcatheter. This happened to be a Magique, and we're out into the fistula through the PCA. I ended up using glue at this time because onyx was not as yet approved in the United States. And this was about a 10-minute injection. Most of the time, you can't get that long an injection because you're worried about gluing your catheter in place. But there are some things that you can do to keep the glue from polymerizing. You can put more thiodol in, and you can actually put glacial acetic acid. The thiodol comes with the kit. The glacial acetic acid you have to get from the pharmacy, and they usually get all excited when you're taking it to radiology. They say, why are you having glacial acetic acid? What you're doing is supplying hydrogen because it's the cations that are causing the polymerization. So if you have the hydrogen, it makes it better. This is after we injected the glue. Notice that the PCA really isn't filling. The ACA is now taking over. And I would say that this child was at some risk for hemorrhage. Notice the stenosis in this vein as it's going into the sagittal sinus. 5 months later, we went up looking for a branch posteriorly, and we placed a little bit of onyx in there. You can see the onyx. Now, the glue is relatively dense because of the thiodol. The onyx is also relatively dense because there's a tantalum mixed in, suspended in. I'll show you in just a moment, though, how it changes over a year. So this is right when we finish the embolization. This is a year later, and you'll notice that the onyx is more difficult to see. This is when we had to re-embolize this ACA. And that's an important concept with kids. We looked at about 1,100, 1,200 pediatric angiograms and found that the complication is very low. Complication rate is very low. The reason we were doing that is because we wanted to see what we're going to do with the recurrence rate. And it turns out that AVMs in kids recur 10 to 12%, even though it's been confirmed that it's gone, meaning either through embolization or radiotherapy or surgery or a combination. About 10, 12%, they come back. And so you need to do a follow-up as they get to be adults. And I think that's very important. This is after we embolize that ACA branch. You can see we have after we're finished, a very dense opacification, and we don't see any flow after the embolization, either from the carotid or from the vertebral. Notice how the PCA has changed and is very small. The ACA is actually filling from the left side. But there's our glue cast. There's our onyx. It's disappearing. And now 7 years after it's injected, you can't see that. I think what's happened is that it's been the material has been phagocytized and the tantalum has disappeared. I've also seen with glue over the course of years that it also will disappear. So on a CT, we have an intraventricular hemorrhage, and you see it also right here in the area of the trigone and a little bit of blood in the parenchyma. On the MR, it's kind of subtle. The abnormality is right here, and somebody could say, well, maybe this is a cavernoma. It can't really be a cavernoma because the hemosiderin ring is incomplete. Yes, cavernomas do bleed. The question is how much, and where they get into the ventricles or subarachnoid space, they're ordinarily on the surface. But then when you do an arteriogram, this is the AP, this is the lateral. Notice in the lateral that the straight sinus is filling, and you see the area of the torcula with a little bit of contrast in it. And as you go a little later in the sequence, now you can see it very nicely coming down. And the area of the nidus is right in here. Now, that's very difficult to see, to have that nidus when it's that small. And if you were to treat this, you would have to do it with a combination of arteriography, treat it with radiotherapy. I don't think anybody would try to operate on this, but you would treat it with radiotherapy, and finding and defining that target is really important. This one's not quite as subtle. Huge round structures, intraventricular hemorrhage, little hydrocephalus, little subarachnoid hemorrhage, doesn't surprise. When you do the arteriogram, the vessels in the neck are huge. You're saying, what is going on? But you also notice just a moment later, you've got these huge veins coming back. And when you do the arteriogram, the right carotid hypertrophies, the right A1 across the left A1 into this fistula. This left carotid is getting into the fistula. Those are all those round structures that we saw. And here, the vertebral is coming up, the basilar is big, and we have a branch, probably the PCOM, also going into it. So supplied multiple different directions. What one would want to do there is obstruct that fistula's point with combination probably of coils and either liquid material such as onyx. The advantage to onyx is you can inject it for a longer time. The advantage to NBCA is you can get a very quick occlusion. But if it's flying through the fistula, you've got to do something to get it where it can polymerize, which means you need to obstruct some of those vessels and at the site. So what we're trying to do is, with our angiography, is get the size of the AVM, its location, how it's supplied, the venous drainage, how fast is it going? Because that means which type of embol, say, are you going to use? Are you going to use glue? Are you going to use onyx? The advantage to using glue is you can use flow-guided catheters. The disadvantage is you can only inject very small coils, and it can be difficult because the Magic catheter is very soft and it's very difficult to maneuver a guide wire through it. Where onyx has all those advantages where you can use a standard 014 guide wire and catheter system. And what you're worried about is choosing the right catheter. If you decide that you're going to use the microcatheter for glue, now you can't use onyx because you need it to be DMSO compatible. The other thing that one is important is, are there other aneurysms? Meaning other lesions, an arterial aneurysm, a nidal aneurysm, or a venous aneurysm. As venous aneurysms at times are associated with stenoses, and many people think that that's the reason that the AVMs rupture, is they pouring all that blood and the vein is not used to it, and it can't restrict the flow sufficiently. This is Dr. Spetzler and Dr. Martin's grading system for AVMs. I'm sure you're all familiar with that, but the thing that it really takes into mind is the size and the eloquence and the drainage pattern. And they looked at their patients that they had operated on in the varying grading scale, and they saw that the patients where they did the grade 5s, they had some significant morbidity, and they didn't have any mortality in this study. Whereas the grade 1s, which would be an AVM smaller than 2 centimeters, outside an eloquent area, eloquence, as we know, sensory motor cortex, vision, speech, and obviously the brainstem. So very important things to know. This is measurements. We're doing this with the computer, and I think you have to be careful knowing about your computer, how successful your angiographic equipment is being accurate. So many times, particularly in some of the studies, we would have to put a marker, usually either a dime or a centimeter marker, so that we could correct for magnification and minification. So this is greater than 6 centimeters, so you get 3. Drainage is deep. It's going to the vena galen and the basal vena Rosenthal, the straight sinus, and it's eloquent because it's in sensory motor. So it's a 5. These are after another patient who has a hemorrhage into the ventricle, and you can see these calcifications. And what's interesting about this case is that most of the AVM has been filled by that right side. And what we're doing is we're seeing the collateral supply to the brain. So here's our AVM, here's our PCA. Now we have the ACA getting filled retrograde because it's an arterial steal. And the same thing with the middle cerebral. The middle cerebral is getting filled from the PCA collaterals, PEEL collaterals. Another large AVM with calcifications. CT is very good at detecting those calcifications. MR, with a lot of experience, you can be more accurate, but even so, it's not as accurate. The sagittal view in the MR, see the area of the nidus and the destroyed brain, and now you have a large venous aneurysm. The arteriogram, as we're finishing, see the calcification back here, but notice this branch in the lateral view. There's an aneurysm on it, and there's another aneurysm right here. So that MCA branch and the PCA both have aneurysms, and those are the cause of what you have to worry about, the hemorrhage. So the question that comes, what do you do? Talked about it a bit, that the older patients maybe not doing as much. What has happened to the AVM? If they had a hemorrhage 20 years ago, and now they're okay, now they're 40, now they're 60. You have to figure those things out and discuss it with your patient. Radiosurgery can play a part. Nowadays, most of it is gamma knife. The gamma knife has better response rate than the LINAC. The LINAC would be a standard radiotherapy tool that just rotates around the patient. So maybe get about a 50% occlusion rate with LINAC, and it's more on the 80 to 90% at 3 years in these all comers. The small AVMs, it's more towards the 90%. The very large AVMs, it's more like 80%. When the AVM is partially treated, you don't protect the patient from hemorrhage. I mean, it doesn't do anything to stop that. It might help with the seizures. It might help with the headaches. So this is a study that has caused a lot of consternation, Aruba. And someone had decided when the study was being conducted, Dr. Moore in New York had decided that we need to evaluate what happens to these patients and where we're getting the morbidity and the mortality. And someone has decided that to enter the patients in the study, and it took them a while to get these patients. And they actually, the way that they finally did it, you'll notice it's 6 years, the way they got to significance is they kept adding years with their number of patients. And they weren't studied for 20 years. You can see it's only a 6-year interval. And the only ones who were really evaluated for that 6 years were the first ones in. And what they concluded is that the complication rate with surgery, with embolization, with radiosurgery was worse than the natural history. And remember, this is for unruptured AVMs. I think most people think if an AVM has ruptured and can be treated, it should be treated unless there are other comorbidities. So a bunch of folks also, after this had been published, looked again at their patients, and they found that maybe it isn't as bad as that they had in Aruba. And so a lot of confusion, caused a lot of consternation amongst people. You know, what should we be doing with those patients? So at SNIS this year in San Diego, there's a consortium of comprehensive stroke centers. So there are 18 stroke centers. The primary site was at the Cleveland Clinic, and they looked at surgery in Aruba and in their experience. In Aruba, the complication rate was 31%. It was only 9% in their particular study, and they had 173 patients in that study. The impairment, so increase in the MRS in the surgery in Aruba was 46%. It was 25% in the consortium study. So I think a lot of people are now realizing that if one is experienced and has the advantages of having all the modalities, one can achieve a very satisfactory result. So we talked a little bit about the morbidity and mortality, and these are varying studies. This is one from Michelson in clinical neurosurgery over a 20-year period. 33% of the patients were well, 22% had some mild deficits, 30% were disabled, and that's a significant proportion, and 10% were dead. I mean, this is a significant disease, hence why people want to treat it. What are we doing with our therapy? Well, we're trying to eliminate the risk for hemorrhage. Yes, we'd like to eliminate seizures. Again, that brain focus may be associated with it. It may not. And you can see all the combinations of therapy that we have. So they have looked in active neurochirurgia. They had about 11% mortality with all grades, Spetzler-Martin grades of AVMs. They had some significant deficits in the higher grades, 4s and 5s, but in the lower grades, 1 through 3s. And I would say that's probably most people's experience, is that in the lower grades, the patients do pretty well, and in the higher grades, they don't. Radiosurgery, that's obviously very attractive because the patient doesn't have to undergo the craniotomy. And you can see the statistics. The important thing to realize is that it takes a while for it to work. So a minimum of 2 years, and occasionally in a year, you'll see, and I'll show you some changes. You can shrink it, but even after it's gone, there may be some rebleeding or bleeding for the first time, even though you can't see it. Even though it's gone, patients can still have a hemorrhage. And you also have to worry about delayed complications. The feared complications is radiation necrosis, and it's usually manifested by swelling, contrast enhancement in the area, making it difficult. is that recurrent AVM. Oftentimes what you have to do is an arteriogram to help differentiate everything. SWI imaging, susceptibility weight imaging, without and with contrast, can show you shunting. And there's an article by Bharathi Jagadeesan when he was here demonstrating the effects in stroke very nicely. So initial AVM prior to therapy in 2003, large, 1 year in 2004. And one of the advantages to being at the same place for the last 45 years is you get a lot of follow-up in patients. So much better. And now in 2005, 2 years, it's gone. Most of the time, we'll wait 3 years. And if it's still decreasing in size, we'll wait an additional couple of years. If it isn't changed, often think of retreating. And when you retreat, you have to worry about the effects of therapy. Your radiation changes. Patient with a small nidus and an aneurysm, a supplying artery aneurysm, nidal aneurysm, and with radiation therapy, after a year, you'll see that it is smaller. This is the one on the right. So from that size to that size. And I've even seen some on the lenticular striates where the striate will return to normal size and the aneurysm will have been completely obliterated. So now we're going to get to the things that the interventionalist likes to do, and that's embolize AVMs. Transarterial, transvenous, and direct puncture. I've never done a direct puncture of a brain AVM. I've certainly done scalp and spine AVMs and tumors, but not brain AVMs. Transvenous is turning into a bigger way of achieving a complete occlusion. That is, the vein is taken out. And I'm going to show you a couple of cases where arterially, you don't see the nidus and you don't see the veins, but unless the vein is gone, just like with a dural fistula, you have the risk of it coming back. So it's been pioneered by René Chapeau in Germany, and he writes eloquently, and I've seen him give some talks. It is an involved process of going retrograde, and it's particularly good if you have a single vein. However, you have to make certain that you've obliterated it. If you just obstruct the vein and you don't get the arterial component feeding the nidus, you run a high risk of a complication, aka hemorrhage. A lot of different devices for these transarterial embolizations. Most of the time we use a guide wire, occasionally a guide wire type system. Occasionally we will use flow guided microcatheters. When right around 2000, glue was approved for AVMs in the United States by the FDA. And our embolization rate went up considerably. We were doing at least one a week. Now, in 2005, Onyx became available. So they're really different agents. With glue, you're trying to get it into the nidus and the supplying vessel. With Onyx, you're really trying to get it into the nidus. You're trying to occupy all that space. So it's a little different. With glue, oftentimes what you were doing was obstructing those supplying vessels. You're leaving the nidus alone. So it is a little bit different in that respect. The polyvinyl alcohol, PVA, and embospheres, we haven't used that much in the last 20 years, ordinarily using Onyx or glue. Occasionally we'll use some coils, Hillall coils, and there's some tornado coils that can obstruct vessels and slow it down so that whatever you're using has a place to stick. We used to have detachable balloons. The Apollo, for a while, Stryker was making it, and it became a regulatory nightmare in trying to produce the appropriate number, and evidently economically it didn't make sense, and it's been discontinued. This is for historical purposes. Large frontal parietal AVM, and you see all these dots. These are actually silastic spears, and they've been injected through a catheter in the carotid artery. And that's the way we treated things in the late 80s and early 90s. What you were relying on was flow. So all those things that we do now, we couldn't do then because we didn't have the microcatheters. The problem with these spheres, though, is you were limited to the size of your catheter, and you injected them as long as that you had flow into the nidus. Now, the problem came, the rest of the brain is perfused, not just the AVM. And when would you stop? Usually a syringe too late or an embolus too late. And your size was limited to the largest inner diameter of whatever catheter that you had. And at the time, our catheters were 6 or 7 French, and they were relatively thick walled. So the lumen would be 038. So you couldn't put very large material through. Another AVM, kind of similar to the patient I just showed you, lots of venous ectasia, some stenoses, and she had this aneurysm, which developed over the course of several years, and this little excrescence also developed. Since it was an enlarging aneurysm and changing, we decided to treat that aneurysm endovascularly, placed a catheter into the aneurysm with a guide wire, placed a stent. This is an Elvis stent from the right A12 junction back into the left, trapping the catheter, placed several coils, actually relatively good, but somewhat incompletely filled. The patient had a hemorrhage, unknown reasons, so we stopped. And we reversed the heparin and we waited, and the patient recovered very nicely. But when we finished, there was still contrast within the aneurysm. A year later, with that stent in place, the aneurysm is completely occluded. So the manufacturer would say that there's some flow diversion capabilities with these particular stents, and there's certainly more metal. But the important thing is she's got a grade 5 AVM. Not going to do anything with the AVM, but we're going to, because most people think that enlarging aneurysms, irregular aneurysms, are the ones that are going to rupture. And we're trying to prevent her from having a subarachnoid hemorrhage. Numerous detachable coils. There are numerous mechanical coils that one can use. The advantage to the detachable coils, if it isn't in a position that you like, or it isn't in the size, it's too big or too small, you can remove it. Where if you're injecting it or pushing with a guide wire, you can't. It's there. There's nothing else. So large left cerebellar AVM had ruptured. This is the arteriogram. You can see the PCA and the SCA and the SCA supplying it. And in the lateral view, you see pica, you see the SCAs coming out the superior vermian arteries, getting to this huge venous collection. The flow was so rapid, we tried to put a coil and it went immediately through the fistula in the lungs. I mean, it was like a gunshot. What we had to do with this is actually get a reverse loaded tornado. And the tornadoes, if it's big enough, would then sit in the wall. If it's too small, it would just stretch out. So we were able to slow this down, and eventually we were able to glue it. We didn't have onyx at the time. And Dr. Dacey, our chairman of neurosurgery, removed it. But the young man at the time was 17. And this is him right here. He's in Kazan, which is in Tarzistan. He is the translator for Hillary Clinton when she visited Tazaristan. we got a very nice note from the educational minister of Tazaristan. So whenever people talk about interventional things, they always want to have new ideas, new devices. And the physicians are the ones, and even though I listed that disclosure up at the top, people kind of gloss over it. I don't gloss over it because I'm proud if I thought of something. And you need to have the brains enough to think of something, and then you need to have an engineer who can help you make it. And then it takes a lot of time, and a lot of money, and it's very, very difficult to do successfully. There's a couple of pathways in the United States, 510K, which means it's substantially the same as any other device. And ordinarily that approval is pretty easy. The PMA is pre-market approval, and that's for the devices that are risky. I was speaking with Yushena the other day, and he indicated that in Nigeria, you have a similar structure with an FDA-like bureaucracy to enable you folks to use varying devices and develop devices. In Europe, previously, all one had to do was show safety. In the United States, it was safety and efficacy. In Europe, they're now going backwards as they have to get these devices reapproved. They're also going to have to show safety and efficacy. It's a big deal about on-label and off-label in the United States. And if you use things off-label, these are just Medtronic's Department of Justice settlements. And it's $70-some million. That's a lot of money. And what happens is that people use it off-label. A bigger deal, I was giving a talk in California to some Chinese neurosurgeons, and we were discussing flow diverters at the time. And we discussed on-label versus off-label. And when I discussed off-label, there was almost an uproar. They said, we can't do that in our country because the patients will, and their families, if there's a complication, will come after them physically and beat them, and even their reports of killing them. So I think you have to see what's going on in your country. So our goal when we're embolizing cerebral AVMs is to get the nidus. And we want to get as much of that nidus as we can. And it turns out that some of the other devices probably would be a little better. So glue, more of a arterial feeder, Onyx, more of a nidus. There is Phil, which is coming from Terumo, but is not approved in the United States, and they're only doing a dural AVM trial. I think they're expecting that people will use it off-label. I think they run a risk that if it looks like they are suggesting that possibility, that isn't appropriate. The advantage to Phil is that the iodine compound is covalently bonded to the material. The other material that's now coming is squid, and that's from Balt. And Balt uses smaller particles, so it's Onyx, but it's smaller particles, so it's not as dense, and you can actually see through it. It works very nicely in areas in the spine and in the head. From what I've seen in Europe, again, it's not approved in the United States, and they're just doing a trial for middle meningeal embolizations. So there's the commissioner in the patent office, Charles Duell, and he, I think, said partly tongue-in-cheek, everything that can be invented has been invented. So I have testified before the FDA on a couple of occasions, and it's interesting. The FDA evaluates these things, and it's almost like they don't want additional things to be approved. They look for reasons that, hey, how is this different? Why do we need this? And I think one of the reasons that they do that, they also are part of the government, and CMS doesn't want to pay for things. Mr. Duell ended up leaving the patent office and ended up as a judge in New York and had a very successful career. So endovascularly, early in the 80s and early 90s was primarily flow. And I stopped doing AVMs in the middle of the 80s just because I couldn't control where the emboli were going. And finally, in the late 80s, early 90s, although they weren't available to everyone, were the microcatheters and the microguide wires, which made access to the nidus, to the area that you wanted to treat. Before, we were always remote. They also brought better catheters to guide you there and give you stability. In the mid-90s, we had the development of the GDC coils. There were other coils before that, but the GDC coils were detachable. And then they modified the coils so that they would have better thrombogenicity. So with brain AVMs, you get a cure somewhere 5 to 50%. And it is interesting and one of the problems comes with a relatively large AVM. You can't see through it and it looks like it's gone. And the only way that you can really tell that it's gone is if you don't see any venous filling. And that's the only way. And you have to figure out how you're going to get there to achieve that. So this is a young man who has a right temporal AVM. It's fed by the right PCA and branches, drains to the vein of the bay and the middle cerebral vein. This is from the vert injection. There is the nidus. There's the enlarged PCA. You can see the varying drainage in oblique. And now we've gotten into the area of the nidus very close to the vein. And sometimes you'll actually get across the nidus and into the vein. And then you have to figure out what you're going to do. The place where I have the most trouble as an interventionalist is when the neurosurgeon doesn't know exactly what they want to do. And they say, see what you can get. Well, that's a problem. Their problem are those vessels deep to the bed. Usually they're perforators. And my problem is those vessels are so small that the complication rate, that's where I get the complications. I don't get them as often when I'm in a relatively large vessel. So we injected onyx. Here's our cast of the onyx. You can see it non-subtracted. Came back a month later to inject some more because it was not completely gone. Well, a month later, it was. They took this patient to the OR and removed the AVM. And what was interesting to me with that, they saw the onyx in a portion of the AVM, but there were other portions, channels, where there wasn't anything. And I wonder when these people claim that the AVM is completely occluded, because it sure looks completely occluded to me there. But at the time of the operation, for sure, it was filling. It was live. Show one more. Large AVM. This is in our days of injecting Hillall coils, trying to slow things down. We can see the varying branches, and you try to take, in general, the biggest branch that you can to begin with, and then work in the smaller branches with the idea that those smaller branches might hypertrophy while you're waiting to do the next embolization. And we do our embolizations roughly a month apart. I know there's some places that'll bring a patient in on Monday and embolize, and then on Friday, do it again. I think it takes the brain a longer time to get accustomed to what that flow is going. Remember, the flow that you're obstructing, like we did right here in this left-sided screen, that you're obstructing, that flow has to go someplace. And the rest of the brain has been used to having not as much blood. And so it's maximally dilated. Now you're dumping that blood into those maximally dilated spaces, which they're not used to, and they can't adjust quickly enough. And that's where you get the so-called normal perfusion pressure breakthrough. You see how we've obstructed things. And this is probably one of the last ones where we didn't embolize the nidus. At the time, onyx was not available. This is pre-embolization, post-embolization, and this is after surgery. So I think that we can make things a lot safer. So in summary, AVMs are a significant disease, as you all know. The treatment of it is also significant, and one has to exercise judgment. What are the combinations of therapy that will give the best opportunity for this patient to have a long and successful life? Thanks. I'll answer any questions.
Well, thank you so much, Dr. Moran. We have questions in the Q&A. But before we do that, I'm going to ask one of my colleagues here in Lagos, Dr. Tayo, to just get ready. Tayo, are you ready?
Oh, yes, I am, Prof.
Okay. Let me see. Uchi, can you just help make him a co-host so that he can share his screen?
I'm already a co-host.
Okay, so we'll just quickly take your presentation and then we'll just sort of take all the questions together, if that's okay.
Okay.
I'm sorry, I can't hear you.
Can you hear me now?
Well, maybe a little better, but I didn't hear the question. I apologize.
We are going to take a short presentation and then we'll take questions. In the meantime, please, if there are questions in the audience, can we please just write them down, and Dr. Okafo will fill them and will read them out for you, Dr. Moran. Thank you.
Again, I have to apologize.
Oh. Can you hear me?
Tyler, we can. Just go ahead.
Oh, okay. I see the question now.
Right. Thank you very much.
Yes, I see the question now. You're asking, how do one know it's amenable to embolization? If there is a relatively safe vessel, and the way we used to determine it, we do our patients under anesthesia now because we only embolize if we're going to fill the vessel that fills the AVM. Back in the old days, we would do them awake and we would inject amytal to see if there was any effect. And amytal tests sometimes were good. If you had a deficit, for sure you didn't want to embolize that vessel. If you didn't have a deficit, you still had to decide, do I want to embolize that vessel? So you needed to know your anatomy and which part of the AVM that you are going to be filling. And that's, again, it's experience in doing things. I know much more now than I did 25 years ago.
And I'm sure we all do today. All right, thank you, sir. Ty, I think you can go ahead. We'll handle other questions later.
All right, thank you very much for giving me the opportunity to share the experience we have from the Lagos hand. Of course, we haven't done as much as the previous speaker, definitely, but we have been trying. I have had about 6 cases, and not just that we have seen 6 cases from the Lagos hand, we have seen quite more, and some of them are probably too large to be approached with a facility that is available locally. And I must say that all the patients we have, were managed surgically, and I'm not sure of the facilities for endovascular management for AVM. So I've chosen to talk about 2 cases. One 22-year-old female who had adult onset seizure, which in the past few months before presentation was getting worse, up to 3 to 4 times every day. He was referred from another center, and at that center, an attempt was made to resect the AVM, but the attempt was abandoned because of significant blood loss and difficulty in controlling hemostasis. So as a result of the attempted resection, it came with left hemiplegia, which had since gotten better. By the time we saw, it was quite anxious, of course, from the previous experience, and the power was 2 to 3 in the left upper and lower limb. The GCS was 15. So we had a look at the CT angiogram that was done, which is very, very important to be able to know what was feeding the AVM and where the AVM was draining. The size was about 2 centimeters and it was draining superficially, and the lesion was quite close to motor strip, hence the reason for his hemiplegia. So we looked again carefully to be sure of where the feeder was, because it's very important if you're going to take out an AVM to have a 3D anatomy of the vascular supply, the artery, and also the draining vein. So at the reconstruction, it was clear it was coming from a branch of the medial cerebral artery. We used the standard protocol and procedure to isolate as if we were coning down to the blood vessel, to the feeding vessel, and we went around the lesion. It had a capsule, no, a cleavage for which we could dissect through, and this was the draining vein, which we preserved until the end of the surgery. And before we took out the draining vein, we could see the feeding artery, and this was carefully done. The post-op image, good. Patient did very well. Histology showed it was AVM. After the surgery, he had dense hemiparesis, which got better in 3 months, and within 6 months, he was back to his legs. He had significant improvement in seizure control, having seizure maybe once in 2 months. The second case is at the extreme end of the experience that I've had. The first one was about 2 centimeters. It was about 10 centimeters. He also presented with seizure and with hemiparesis, for which it was quite difficult for him to talk because of the lesion being in the speech center. And this is the intraoperative view. This was the pre-op view. But importantly here, he had more than one feeding vessel, and clearly the M2 was quite close to the lesion, but was not part of the lesion. So this was a defining moment because it had to be spared. This was the intraoperative view. We've isolated the nidus. This is the the draining vein. And below this, we found the feeding artery. And this was just the artery that was close to the lesion, but was not part of the lesion. It was quite important to spare that, and we did, and the patient did very well. So the size was 10 centimeters, as we could see from the nidus post-excision, and it was draining superficially, and it was on the speech center. Patient did very well. 3 months later, there was a repeat angiogram. This was the before angiography, before the surgery, and post-op, the lesion had been completely excised. Patient is now walking, but is still struggling to talk properly. But before the surgery, couldn't talk at all. That has been the experience I would like to present. And like I said, just the 2 extremes, the smallest and the largest. But in between were many cases that we couldn't do because of the facilities that we don't have. Thank you.
All right, thank you very much, Dr. Joe. Uchenna, I'm going to hand over to you, Dr. Kafo. Let's continue the rest of the presentation.
Thank you very much, Dr. Bankole. Thank you, Dr. Moran, for an excellent presentation this morning, as always. Also, Dr. Ojo, thank you so much for sharing your reflections on some of the cases already handled surgically, AVM cases handled surgically in Luth. We have a few questions that are on the chat. I think Dr. Moran tried to answer one of them already. So Dr. Moran, if we still have you on, there's one that mentions it talks about, it says, this is from Fred Ejumodo. Thank you for sharing your question. It says, thank you for your presentation. It says, in developing countries where there are no facilities for pre-operative embolization, what do you advise for Class A AVMs or low-grade AVMs with arterial feeders from multiple vascular territories? Dr. Moran.
That's back to the old days. It's very unfortunate. I would be in the OR doing intraoperative angiography. Sometimes the surgeons would be there 18, 24, 30 hours, and the entire blood volume would be replaced a couple of times. And the patients would, since it was banked blood and didn't coagulate normally, I mean, it was a bloody mess. And literally, not just because of the English background there, it is indeed. And it's very difficult.
Okay. We are currently trying to develop practice neurointerventional services at Luth in Lagos University Hospital with Dr. Bankole, Dr. Joe, and the blessing of the Nigerian Association of Neurological Surgeons and its president. But I kind of wonder, Dr. Moran, would they be able to at least utilize, gamma knife or at least some radiotherapy before they attempt some of those procedures?
Well, for gamma knife, the lesions need to be smaller. I mean, or multiple targets. I mean, that is one of the alternatives, or operating on what you can operate in the residual, the deep part, perhaps gamma knife or even Linac. Linac is not ideal, but we used it for a while because we didn't have gamma knife. I mean, those are very difficult problems.
Okay. Just as a matter of interest, Dr. Michael, do you guys have gamma knife or just the Linac available at Luth?
We only have the Linac. We do not have gamma knife. There's no gamma knife facility in Nigeria in general. There are a few Linacs, but no gamma knife facilities.
Okay. Dr. Moran, we have another question for you. It says, how does one know that an AVM is suitable for embolization? This is from Joseph Ikunobe. Thank you for sending that question.
Well, in general, what we do is, depending on the size, are we trying to reduce it for surgery? Are we trying to reduce it for gamma knife? Do we have a vessel which is appropriate to embolize? Again, those perforators, the anterior choroidal, posterior choroidals, the ventricular strides, those are fraught with danger. And I really prefer not doing those. But, in middle cerebral vessels, as long as it's supplying a relatively silent area of the brain, the sensory motor cortex is in the older patients doesn't tolerate it very well to have a lesion there and B, to have it embolized. So sometimes it's better not to do something.
Thank you very much. I'm not sure if anybody has, excuse me. I'm sure anybody has a question to ask you. Just unmute yourself. We have about a minute left. If you've not had the opportunity to type it into the chat, we have Dr. Moran still available. Anybody who wants to unmute and ask a question directly? Okay. Okay, I think that's pretty to say. So Dr. Moran, thank you so very much. We really appreciate you giving your time to share with us. We have most of the team from the Nigerian Association of Neurological Surgeons in Nigeria who are on the Zoom call this morning. Thank you very much for your time. And we're looking forward to getting you down to Nigeria to help us as we start off the services out there as soon as we can get the machine down there. And
Thank you for your kind invitation. Thank you.
Thank you, sir. Over to you, Dr. Bankole. Dr. Bankole is still there?
I'm sorry. Can you hear me?
No, we can hear you. We're
Okay.
just asking to, we're just going to round up because our time is up. We're just going to ask Dr. Bankole to round us off if he's still on the line. Okay, I'm not sure. Is Dr. Bankole still there as he left?
Dr. Okafor, maybe you just go ahead.
Okay, that's fine. All right, thank you so much, everyone, for joining us. As our manner is, we are going to have another presentation in October, 18th of October. It's going to be on endovascular treatment of retinoblastomas. We've had another service available in Lagos that has already offered such a treatment. We're using a monoplane machine, and we applaud the efforts. We're going to have Dr. Marsha Martinez, who will be giving us that presentation. And we're really, really looking forward to that talk on the 18th of October. I want to thank everyone who has attended today. I want to thank Dr. Moran, our speaker, Dr. Tayo Joe. Thank you so much for sharing those reflections on, the efforts already being made in surgical resection of AVMs in the Lagos University Teaching Hospital. I want to thank our Dr. Bankole as well, who has pretty much put this together and made this possible, this collaboration possible. We're really looking forward to the fundraising drive to raise enough funds to get our biplane machine in Louth, and we're looking forward to also getting getting people trained as well locally, which will be wonderful. With the international collaboration with our team at the Mallinckrodt Institute of Neuroradiology and in WashU and other places, we hope that this will come to reality. The services already started off in Ethiopia with TECL, and we're hoping we can do this for West Africa as well. Thank you for your time, and we'll see you back in October. Thank you.
Thank you. Thank you, Dr. Okafor.
Thank you, everyone.
Thank you, everyone. Bye.